do those folks in rural Minnesota or greater Minnesota get connected with an MDA clinic, such as folks that would go to Mayo Clinic? I'm sure you're well aware of Mayo Clinic's reputation. Do they refer people out to MD clinics, or is it something you have to seek after?
So, okay, yeah, it's a challenge to figure out the microphones. So for MDA clinics, we want to make certain that we have, the best clinics in places that people have access to. But you're right. We don't have clinics everywhere. And in part, it's because we don't have doctors with the expertise in every city where we feel we need a clinic. So we're looking at different models of how to have an MDA clinic. We have different technology these days. There's a lot of medicine being done by telemedicine. And we want to make certain that everybody has access to the kind of care that people here in Minneapolis have. But we don't have those teams everywhere across the country, and particularly in the northern tier of states where the geography is large and the populations are small. It's hard to have the expertise in the clinic that we need. So we're looking at different ways to have an MDA clinic. Can we have outreach clinics? We have some states where our clinic directors are based, and Iowa's a good example. We have a clinic team that's based in Iowa City, and they travel around the state of Iowa several times a year and have outreach clinics. So that's one way to do it. The other way is, like I said, is electronically via telemedicine. So we're looking at all these kinds of models to make certain that people in every geographic location have access to an MDA clinic with a great team of medical providers. Great question.
Additional questions? And just so if you would rather not say it out loud, you're welcome to write it on a piece of paper and slip it to me, and everyone will see that happen, and they'll know who it came from. Any questions?
I have my phone. I'm just wondering if you have any additional developments in FSHD research?
So FSHD, we couldn't talk about everything this evening, but we're finally starting to understand FSHD. The last year or two have really allowed for an understanding of what's causing this disease through the DUX4 gene, and it's a complicated disorder, and we won't get into the science tonight, but the bottom line is, by now understanding what the genetic underpinning is, people are starting to work on developing or identifying targets and developing therapies. They're looking at things like antisense therapy for FSHD. So it's a little further back, but it's because understanding the cause of that disease has been so challenging. But now that we've got a much better understanding of that, we're going to start to see things move forward fairly quickly in FSHD.
And I just recently attended, so one of my roles is I attend all the council meetings for the NIH councils, and they were talking about the huge influx of grants that they'd received at the NIAMS, which is the National Institute of Arthritis, Musculoskeletal, and Skin Disease, which is the institute that oversees that jurisdiction, in FSH grants. And so already we're seeing the floodgates open of scientists who are coming in and putting in applications to study FSH, which really just means that we've just opened the door to how robust that field is becoming, which is exactly what we want to happen. So there's a lot happening there. And you actually there's a researcher here funded by MDA who's looking at drug targets at FSH. Yep, Dr. Kaiba.
Thank you.
Additional questions, anybody?
Here.
Yes.
Here. I was wondering if there's any advancements in research for CMT.
So yes, actually, there are a couple of things in CMT, and one of them has to do with understanding the natural history, how CMT progresses. CMT is not one disease, by the way. CMT is Charcot-Marie Tooth disease, for those who are not familiar with it, and it's a nerve disease. And there are multiple types of CMT. There are a couple that are quite common, and then there are others that are more rare. One of the big things that Dr. Michael Schei has been working on is the CMT Clinical Research Network. He has put together a consortium of doctors who are experts in CMT here in the U.S. and also in Europe. So it's an international consortium, and he is working on developing and identifying the natural history, how it progresses, so that we understand what the disease looks like, so that when we're ready for clinical trials, we know what to look for. So that's a very important project. And he's actually developing scales that can be used in clinical trials. The other thing in CMT is that people are looking at a spice called curcumin, which in animal models of CMT is showing some encouraging results. So there is consideration for using that spice or derivatives of it in human clinical trials. So yes, things are starting to happen in CMT as well.
Okay, I have a follow-up question. So how old are you? 12. I love that you asked that question. So the first thing is, just because we're looking at the spice in animal models doesn't mean go home and take it. Because we're not sure that it's going to work the same way in people.
And we don't know how much you would need.
But then the second thing is, if you remember in my presentation, I talked about there are registries that are really important to be a part of. And there is a really big registry for CMT that if you're not already enrolled in the registry, you should go home and have somebody in your family help you enroll in that registry, because there is some really important work coming out of the International CMT Registry, and you can link to it from the MDA website if you're not already familiar with it, because that's a really important way to stay involved and engaged in what's happening in CMT.
Okay, I think.
Way to ask a question here. Thumbs up. You need to come work for MDA at some point, when you're old enough to get a workplace.
That's right.
My mom also wants me to ask about the internships in Washington, D.C.
Okay, so you have to be in college, and then you can send me an email and tell me that you were the guy who asked me a question in Minnesota. No, I'm not kidding. In Minnesota when you were 12, and you can have an internship in Washington.
Maybe I'll speak on behalf of the MDA team and tell you you need to give Bryce the internship.
Yeah, it's a done deal. It's cool.
Other questions?
I'm not even sure exactly how to ask this question. We're in our first year with this, so our heads are spinning in a variety of ways. And one of the our family is in the Duchenne Becker spectrum, and we have been approached by people who are their family and their supporters have a little bit more of a narrower focus. And they will say, MDA, and by the way, MDA has been absolutely phenomenal. What a great organization. We are big supporters. But we've had people say, if you support our cause, it's more narrow to what you care about. And MDA has like 43 diseases. Are there some good ways to respond to that? And how do you work together with when people are saying, a narrower focus might be more meaningful for your family?
So I guess the first thing is MDA, we work very hard to work collaboratively with all the other organizations, sister organizations in our space. And there are a lot for all of the different disorders. There are a lot of other organizations. And all the other organizations have different focuses. So they've developed for one reason or another. Some are family foundations. Some have a different policy agenda than we do. But wherever we can, we do work pretty well together, I have to say. But I will say with respect to Duchenne Becker, and we call it Duchenne Becker because it's a spectrum, MDA funds more research for Duchenne Becker than all of those other groups combined, period. So there are 47 other groups in the US right now. And so that's how we answer that. And so, you know, and that's not, and there are great groups out there doing good work. And we actually, with the MD Care Act, we're partnering with PPMD and FED, the Foundation to Eradicate Duchenne, on that legislation because we work very well in advocacy together. But as far as what's happening in research and services and a laser focus, nobody has a laser focus like MDA in funding, research funding for Duchenne. And nobody ever has. So the Duchenne gene was funded by MDA. The clinical research infrastructure for Duchenne is being funded by MDA. And so, you know, that's just the answer to that is nobody's funding more. So, and you know, I go back to that umbrella of 43 is very powerful because what's happening in one other type of neuromuscular disease is informing what's happening in others. And so we learn from SMA and apply it to ALS. We learn from myotonic and apply it to ALS and vice versa. I was at our last scientific conference and there was an exon skipping presentation and two scientists who never, ever, ever would have met each other because they were in different fields gathered next to me. I happened to be sitting in the back with the bloggers. And when one got down, the other went over to him and said, oh my God, I need to meet you because I'm working on blankety blank. And they were talking words that I had no idea what they were talking about. But they never in a million years would have met each other. But now they had something they could work on together and collaborate on. And they were in completely different disease spaces. But that was going to move two different fields forward because they were in this big conference together. And so that is so, so important. And that's sort of an aside to your question. But it's so important, that's the power of MDA. And so that's outside those funding silos, but that's the power of moving these fields forward. And thank you for your support.
I would add to that also beyond research, MDA has such a broad spectrum of support for the people they serve. I think a lot of these other groups don't get that broad what they do to support the
You're right. I mean, every organization has its mission and has its focus. And you know, ours is to make certain that we're moving, you know, that needle forward as quickly as possible on research. But we also need to make certain that we're helping people today, because you know, we know that we need to work on both aspects. So thank you.
This wasn't my question, I'd like to go back to that, but in answering the one that you just did, I would imagine that you're working on a registry for what researchers are working on, so that it's not just at a conference where all of a sudden people discover each other. Is that something that is out there? You post a disease and you say, who's doing something on this?
Well, they publish, just answer that.
Yeah. Well, so we require that our researchers publish results from their projects so that it's publicly available. We also, you know, hosting the scientific conference is hugely helpful because they're all in, you know, in a room together for 3 days and sharing information. And, you know, they're working on all the diseases. So again, you know, the power of the 43 diseases. And we also connect people up individually. So, you know, we may get a question from a researcher, you know, they email us or they call us, and they don't know where to go or who to talk to, and, you know, we'll connect them to who they need to. You know, and certainly we are looking to develop our website to make it more robust for our research community, so that they're not only sharing their positive results of their research, but also sharing the negative results of their research, which is hugely important. Journals don't like to publish negative results, but you know, knowing that something didn't work is as important as knowing that it did work. So, you know, so we're looking at different ways to bring our research community together and to get them to share even more information because they have, you know, they have a lot to learn from each other.
We also have somebody on our team, on our research team, Jane Larkindale, who spends a lot of time fishing, if you will, for people who are working in different spaces to bring them into our field. So people who wouldn't naturally necessarily think about working in neuromuscular disease, but are working on a mechanism of action that might work. So they're working in cardiac somewhere, but might be working on a different cardiac disease altogether, but it might have benefit in a neuromuscular disease. And so she will actively go out and reach out to them and get to know them and see if they might be able to put in a letter of intent to MDA for a grant and work with us. In the same way, she also goes out to industry, to companies, pharmaceutical companies, biotech companies, to bring them into the space and see if once we get, Valerie put up that slide with sort of our pipeline and coming through the pipeline and getting to where we get into industry and development, and that gets really expensive, and we're not interested in paying for that. Like, what you're raising at a walk and are selling shamrocks isn't gonna pay for the millions and millions and billions of dollars. And we don't want that to. That's what companies, pharma, come in to pay for. But we have to draw that pharma into that space after we've paid for all the non-sexy part of the research. And so that's what Jane does, is she helps bring them in, and it's sort of, we call it scientific speed dating, right? You bring industry in, and you sort of pair them up and match them up with scientists who are doing the work, so that when we're done paying for this part of it, you can make a match and create a handoff so that we haven't done all this work for nothing. And so that's some of what MDA is doing, is making sure that when we get things through the pipeline, there's a company on the back end that wants to take it somewhere. And so that's just really important for you to know that, we're not just investing in young scientists, which is really important, but we're also investing in the relationships in the back end.
Thank you for your answer. That was a wonderful answer. I feel like I almost asked a great question.
It was a great question, yes.
And if you have other ideas for ways that we can engage people more, we're always open to new ideas.
MDA is rather new to me, so this question is like, where have I been all this time? But I'm just interested in your drugs. Are you at the stage with drugs, in the ones that you're developing, where you are arresting these diseases only, or are you anywhere near reversing them?
So great questions. And I think as we're thinking about drug development, and when we're thinking about progressive diseases, we're first thinking about slowing the course of the disease. And I think we're at that stage now, especially with the drugs that are in human clinical trials. So the first thing is to have a significant impact on slowing the disease. And then next would be to stop the disease, and then would be to reverse it. If something hits and we skip the slowing and the stopping and went right to the reversing, that would be great. We would love that. But I think, realistically, right now we're probably at the slowing stage. And in reality, for many of the diseases, and maybe even most of them, we're going to need cocktails of treatments to think about stopping and reversing. Because, the things that we're looking at now, like exon skipping, where we can get the dystrophin back in the muscle in Duchenne muscular dystrophy, that's going to slow the disease. We're not going to get 100% of the dystrophin back in. So with exon skipping, we can get some dystrophin back in. And then let's come in with a couple of other drugs that work in different ways to help strengthen the muscle. So, I think we first have to test drugs individually, but then we have to start putting them together as cocktails. And the research community is already working on those cocktails in the animal models. There's a research group at UCLA who's working on making exon skipping work better by combining exon skipping drugs with drugs that are already on the market. And they've shown that dantrolene, a drug that's already on the market, can boost exon skipping. So they're working on that. But right now we're probably on the slowing the progression, then stopping, then reversing.
One of the challenges of a night like this is you're not sure who's in the room. So I'm not sure if anyone here has myasthenia gravis or infantile onset Pompe. All right, so there are some of our disorders that are now considered treatable, and you might be getting some of those treatments. So you're at the myasthenia gravis table. And so the treatment that you receive actually was funded by MDA. So plasmapheresis, that treatment discovery was funded by MDA. So some of the treatments that are now commonly administered, and plasmapheresis isn't only given now for myasthenia gravis, it's actually a treatment that's used in a lot of different disorders. Infantile onset Pompe, now in many kids there is a treatment now for that, and adult onset also. And so some of our disorder, we don't say cure. You'll notice MDA doesn't use the word cure a lot. But we do have some forms of neuromuscular disease that we now have treatments that people respond well to, but as you know, they're not always 100%. And it's not a magic pill that you can now say, all right, well now I'm just a donor to MDA, I'm not served by MDA anymore. And we'd like to get to that point, but we're not there for any of our disorders yet.
I'm at the mycelium gravis table, but